Pharmacies are everywhere. They sit on busy corners, inside grocery stores, and at the center of many neighborhoods. Prescriptions move steadily across the counter. Prices printed on receipts look high. From the outside, it feels obvious that selling medication should be profitable. But for many pharmacies, filling prescriptions barely makes any money at all. In some cases, it loses money. Survival depends on forces most customers never see. Pharmacies matter because they sit at the intersection of healthcare and retail. They are often the most frequent point of contact between patients and the medical system. They influence access, adherence, and public health outcomes. They are also one of the most misunderstood businesses in healthcare. High drug prices create the impression of high margins. In reality, those prices rarely benefit the pharmacy itself. At the center of the pharmacy business is reimbursement. Pharmacies do not set prescription prices the way most retailers do. They are paid after the fact by insurers. A reimbursement is the amount an insurer agrees to pay for dispensing a drug. That amount is determined by contracts the pharmacy has limited control over. Most prescriptions in the United States are paid through insurance, including private plans, Medicare, and Medicaid. When a pharmacy fills a prescription, it submits a claim. The insurer later reimburses the pharmacy based on pre-negotiated rates. Those rates are often far lower than the list price shown to the patient. Between insurers and pharmacies sit pharmacy benefit managers, commonly called PBMs. PBMs are intermediaries that manage prescription drug benefits for insurers and employers. They negotiate prices with manufacturers, set reimbursement rates for pharmacies, and design formularies, which are lists of covered drugs. Their role gives them enormous influence over how money moves through the system. For pharmacies, PBMs largely determine profitability. Reimbursement rates are usually fixed. Sometimes they are adjusted weeks or months later. Pharmacies may not know whether a prescription was profitable until after those adjustments are applied. These adjustments often take the form of performance-based fees tied to metrics like adherence or outcomes. While intended to improve care, they add uncertainty to already thin margins. Margins on prescriptions are small. Often, the difference between what a pharmacy pays to acquire a drug and what it is reimbursed is only a few dollars. Sometimes it is less. In some cases, reimbursement does not even cover the acquisition cost. That creates a negative margin. Filling the prescription produces a loss. High volume does not solve the problem. Pharmacies fill hundreds or thousands of prescriptions each day. Each one carries labor cost, regulatory requirements, and overhead. Pharmacists are highly trained professionals. Their wages reflect that training. Technicians, support staff, rent, security, and technology add fixed costs. When margins are thin, scale increases exposure rather than profit. Cost pressure is constant. Drug acquisition prices change due to supply disruptions, manufacturer pricing, and shortages. Pharmacies usually cannot raise prices to compensate. Reimbursement rates are fixed. When costs rise faster than reimbursements, profitability erodes quickly. This dynamic is visible in large chains like Walgreens. Walgreens operates thousands of pharmacies and fills an enormous number of prescriptions. Prescription sales make up a large share of revenue, yet margins on those prescriptions remain low. Overall profitability depends heavily on front-of-store sales and additional services. Walgreens has repeatedly reported pressure on retail pharmacy margins. Labor shortages, tighter reimbursements, and higher operating costs have weighed on results. In response, The company has invested in clinics, healthcare services, and partnerships that extend beyond dispensing. The goal is to build revenue streams that are not tied to prescription margins alone. A major inflection point came as PBMs consolidated. As fewer PBMs gained control over more prescription volume, pharmacies lost leverage. Contract terms worsened, reimbursement rates tightened, fees increased. Independent pharmacies were hit hardest, lacking the scale to negotiate or absorb losses. Some pharmacies adapted by shifting focus. Over-the-counter medications, personal care items, and convenience goods offer higher margins and more pricing flexibility. Others expanded into vaccinations, testing, and clinical services, where reimbursement structures can be more favorable. Many did not adapt. Pharmacy closures have increased in recent years, especially in rural and underserved areas. These closures reveal the fragility of a business that appears essential but operates under persistent financial strain. The broader lesson extends beyond pharmacies. Some businesses occupy critical positions in large systems but have little control over pricing or margins. They handle volume, complexity, and responsibility without capturing much of the economic value they help create. Profit pools exist elsewhere, often upstream or within administrative layers. Pharmacies show how essential services become commoditized. Dispensing medication is necessary, regulated, and standardized. That standardization improves access and safety. It also limits differentiation. When differentiation disappears, pricing power follows. In the end, pharmacies barely make money on prescriptions because dispensing is not where value is captured in healthcare. It is where value is delivered. The economics reward negotiation, scale, and control over pricing, not the act of filling the prescription. For patients, the pharmacy counter feels central. Economically, it sits closer to the edge.